Dear colleagues, good morning. It's a pleasure to be here. This is my disclosure slide. I will try to talk about the evaluation of women who present with urinary retention. This is actually a very problematic group of patients in terms of diagnosis, pathophysiology, and also treatment. And as a consequence of that, one study has shown that on average, women with retention are seen by 3 hospital consultants before a diagnosis is made. So we have a very difficult task in front of us. David has explained very well the etiology of it, but just briefly, we can, first of all, for the sake of a good evaluation, we can classify the patients with retention into persistent and transient groups. And we know that the pathophysiological mechanism is either related to detrusor underactivity or to increased outlet resistance or to both of them. But it's not only that. In addition, there is a big influence of psychogenic factors, surgical interventions, and comorbidities as possible triggers of retention. So our first goal of evaluation is, of course, to ensure the bladder emptying when we see the patient in front of us. And the best way of doing it is, of course, clean intermittent catheterization. Foley catheterization is usually the choice for acute retention in these patients, and long-term indwelling catheterization should be the choice only for frail patients or when the clean intermittent catheterization cannot be performed. The other goal of the evaluation should be, as always, to make sure that the upper urinary tract is doing well. Unfortunately, there is very limited data in the literature about the risk of upper urinary tract in this patient group, but this is our general rule of functional urology. And in order to do that, it's easy for us to perform a bladder ultrasound and renal function tests to make sure that the upper urinary tract of these patients are doing good. And the third goal of our evaluation is, of course, to find the etiology and to plan the appropriate treatment. Here, there are certain tests, a lot of tests that we can do. Some of them are easy, some of them are sophisticated, difficult to do, costly, and have certain morbidity. We shouldn't hurry to pour all what we have in our hands for the evaluation, especially for the patients that we believe that have transient causes. However, patients with persistent retention will need more invasive neurological evaluations, such as urodynamic studies, cystoscopy, and sphincter EMG, and etc. Here, our evaluation, of course, goes parallel to the clean intermittent catheterization, which is actually also a way of treatment of these patients, because we know that retention will resolve in a group of patients, and this corresponds to about half of the patients, just with CIC, and after eliminating of the transient factors, we know half of the patients will be spontaneously cured. So what are these transient factors that we have to eliminate first in this patient group? First of all, immobility, especially after operations, constipation or fecal impaction, medications, urinary tract infections, delirium, endocrine abnormalities, psychological problems, and, for example, clot retention. There are studies in the literature indicating that half of the women presenting with retention will void normally just after eliminating these transient factors. And so, again, more invasive evaluation should be spared for persistent cases. Well, how should we define persistent female urinary retention? There is no consensus definition in the literature about it. But when we take, for example, iatrogenic cases, we know that a chronic female urinary retention, for example, after sling surgery, has defined with the time limit of 1 month. But here, there is unfortunately not much data or consensus in the literature, but we can define it maybe after eliminating all the transient factors. If the retention still goes on, then we have to talk about persistent female urinary retention. David has explained the etiology of these patients. We can classify in 3 groups as neurogenic, non-neurogenic causes, and idiopathic causes. Neurogenic causes are these ones, as you see on the slide, and the evaluation of this patient group is the same as we evaluate any kind of chronic or persistent lower urinary tract symptom in our patient group. Neurogenic causes are either related again to increased outlet resistance, which is the detusor sphincter dyssynergia in a patient with neurogenic bladder dysfunction, or decreased bladder contractility, such as cauda equina injury, pelvic plexus injury, peripheral neuropathy, and multiple sclerosis. Non-neurogenic causes can again be divided into 2 groups, as increased outlet resistance and decreased bladder contractility. Again, I'm not going to repeat it, but David has very well explored these causes. And finally, we have the idiopathic causes, and under the idiopathic causes, we have to talk about the Fowler syndrome. The basic steps of evaluation is again starting with a detailed history, noting the symptoms: abdominal discomfort, emptying face symptoms, recurrent urinary tract infections, or incontinence. Many patients who even present with acute urinary retention may have actually a chronic urinary retention, but may not be aware that they have chronic urinary retention. And there is also a high-level anxiety, especially seen in adult cases, that we have to deal with. The age group of patients who present with retention usually belongs to the premenopausal area, as you see on the slide. And interestingly, in about half of the cases who present with retention, there is a trigger event. So therefore, in taking history, it's very important to find out this trigger event, because it will be playing an important role also in the treatment. Well, detailed history should further include the childhood voiding history, any previous surgery, especially anti-incontinence or other pelvic surgeries, any comorbidities, especially hormonal ones and diabetes, medications that cause retention, SSRIs, alpha agonists, anticholinergics, calcium channel blockers, opioid analgesics, and psychotropic drugs should be noted, constipation, and gynecological history, namely the endometriosis and polycystic ovaries are important, especially polycystic ovaries are named as being a part of the Fowler syndrome. Physical examination is the same physical examination that we should do in all of our patients, of course, including a focused neurological examination. Many authors believe that renal function tests and urine analysis are mandatory in this patient group as well, and cystoscopy should be a part of the examination according to many authors. Unfortunately, the level of evidence of these evaluation tests are not very high. There is not very high quality data in the literature to recommend all of what I'm showing here. But these are usually great C recommendations from the studies and or expert opinions. So, urodynamic studies. In women who are not in complete retention, uroflowmetry and PVR measurements should be done. Cystometry with pressure flow studies and with anal sphincter EMG usually show a detusor underactivity as the most common finding in this patient group. Pressure flow studies are unfortunately not very useful in differentiating obstructing and non-obstructing cases, again, as I'm going to show in the next slide. Well, ureteral pressure profile is another urodynamic test of debate. The Fowler syndrome is originally defined with a high maximum ureteral closure pressure as noted in UPPs. But the problem with ureter pressure profile is, as we know, the normal values are not well established. And there is a big overlapping and standard errors in UPPs, plus there is a high variation, retest variation in this group. But if you compare the UPP findings with normal, in normal women, you find high maximum ureteral closure pressures in this patient group. And together with an increased sphincteric volume, the Fowler group has proposed that it is a very valuable finding to diagnose the Fowler syndrome, which can maybe replace in the future this sphincteric EMG. What the final and the gold standard method appears to be the video urodynamics should be preferred when available in patients with persistent urinary retention. What we have to know also according to the last ICI in 2013 is no urodynamic test for sure can differentiate neurogenic and non-neurogenic cases from each other. So the diagnosis should be based on our clinical findings of history, physical examination, and also urodynamic and neurological evaluation. What are the problems with pressure flow studies? Well, we know that women empty their bladders by relaxing their pelvic floor without the need of strong Tetsuo contraction, and because of that, unfortunately, we don't have reliable nomograms as we have in men to diagnose obstruction in this patient group, and small changes, very small changes in Tetsuo pressure may define bladder outlet obstruction. But plus, during a pressure flow study, there is an obstructive effect of the catheter and the unnatural environment. Plus, we are dealing with a group of patients who already have difficulty in voiding, so therefore pressure flow studies appear not to be very, very helpful in this patient group. Well, the neurological evaluation to rule out any neurological deficit in this patient group actually starts with our focused neurological examination when we first see the patient. But afterwards, of course, a multidisciplinary work is needed. A neurology consultation, for example, in persistent cases without an anatomic obstruction is favored. MRI appears to be the most commonly utilized radiological method to rule out certain neurological diseases such as multiple sclerosis, tumors, vertebral congenital and acquired pathologies. There are special tests such as bladder cooling reflex, the ice water test, Beta-Nicole spur sensitivity test, and sphincter EMG, and others such as nerve conduction studies. The first three have a level of evidence of 2 by the last ICI to differentiate neurogenic from non-neurogenic patients. Sphincteric EMG is especially valuable, as we know, in Fowler syndrome. This is the test, actually, that diagnoses the Fowler syndrome. The EMG abnormality has 2 characteristics here. First, the decelerating burst, and second, the complex repetitive discharges. It's believed to be a muscle membrane disorder, although the exact pathophysiology has not been elucidated yet. It is believed to be a primary disorder of the sphincter relaxation, and here again it's hypothesized that increased ureteral efferent activity is inhibiting the passage of bladder efferent signals to the brain and resulting in poor sensation, large bladder capacity, and detusor underactivity, as we show in urodynamic studies. This figure is taken from a study of Swin et al. From the Fowler group. On your left-hand side, you see a normal sphincter EMG activity, and on the right-hand side, you see a patient with Fowler syndrome. Of course, the concentric needle EMG is not easy. It requires special equipment, technical expertise, an experienced investigator. And also, although it is done under local anesthesia, it is painful. So the same authors have also proposed, therefore, to propose that UPP in combination with the measurement of the sphincteric volume to be another alternative to diagnose patients with Fowler syndrome. So, talking about Fowler syndrome, although it is listed under the idiopathic causes of female urinary retention, there are interesting findings. For example, a retrospective study has shown that 50% of these patients have unexplained chronic pain syndromes, and 19% are taking opiates. Abdominopelvic surgery with general anesthesia was the leading trigger, approximately in 1/3 of these patients. About 1/4 had functional neurological symptoms such as non-epileptic attacks or leg weakness, and 30% had psychological symptoms. So still we have to do more work on Fowler syndrome to really understand the pathophysiology. So what is the importance in showing the sphincteric abnormality? Well, a recent study by Dr. Rieder and associates have shown that if you can show this sphincteric EMG abnormality, the success of a sacral neural modulation is higher in this patient group. In about 74% of success in patients with Fowler syndrome compared to 46% success in idiopathic cases, other with normal EMG findings. So another important thing is, of course, to differentiate these patients with dysfunctional voiders, because dysfunctional voiders will benefit from biofeedback treatment and pelvic floor exercises, whereas the Fowler syndrome patients will not. So sphincteric EMG, therefore, still carries an importance in the evaluation of these patients in spite of its drawbacks. Well, as a conclusion, I would like to summarize that the multifactorial etiology of female urinary retention is complicated and it is still poorly understood. A considerable amount of patients will have transient causes, and our first aim during evaluation should be to eliminate these causes. CIC should be the way of emptying the bladder until the diagnosis and the treatment is achieved. A good quality video urodynamic study, together with cystoscopy, reaches a great consensus in the literature and should be considered in patients with persistent urinary retention. It's important to note that a multidisciplinary teamwork is favored, including a urologist, physiotherapist, neurologist, gynecologist, psychiatrist, and gastroenterologist or a general surgeon. There are two things that I would like to mention not to do in this patient group. The first one is we should not perform excessive urethral dilatation, which is unfortunately still done, and this is the most common cause of female urethral stenosis as a iatrogenic cause. And we should not label idiopathic cases as psychogenic without completing the psychiatric and neurological workup. So this was my last slide. Thank you very much.